which may require one extra unit of insulin. So that is why we follow the 25 gram serial exchange instead of the 30 or the 50 gram serial exchange. So for this patient, obviously after we intervene, the phosphorus did improve, and we need to talk to the patient's parents importantly with reference to whether it's teaching them a food exchange or top count or fat protein unit. Though fat protein unit is not so much used in our country. This can also be extrapolated to celiac disease, wherein we have food options which we can replace with the gluten sensitive foods. Like we know that the oats and the barley are contaminated with gluten. We have the wheat, which is a source of gluten, which needs to be replaced with healthier options. We have millets, but in millets, we need to choose either the barnyard millet or the foxtail millet, which are glycemic friendly if the patient is a type 1 with celiac disease. So also this can be used in carb loading. So we have another case. If I have about 5 minutes, I'll quickly go through this. We have an 11-year-old child who has celiac disease with hypothyroidism, who's on short-acting and long-acting insulin analog, who's having nocturnal hypoglycemia followed by someogbutamamin in the morning, a poor glycemic control, a poor time in range, and he cycles back home. So what do we need to do for this patient? Obviously, we have the anthropometry. We use the stamp tool for assessing the nutritional status, which says that there is medium risk for malnutrition. We have put down the nutritional PES so that we can get the goals. The goal is I want good blood sugar control. I want to improve the time in range to at least 70%, HbA1c to at least 7%. I don't want the nocturnal hypo. And he's got mild thinness, so improve his weight mildly so that he falls into normal BMI. And obviously these are the glycemic targets. And I remember that the patient is on short and long-acting insulin analog. So I have to synchronize his meal with the timing of the insulin. And remember, he's cycling back home, so he may go at hypoglycemia between his cycling back home from school to home. So keep that in mind to give at least one carbohydrate count. And also remember that we need to, most importantly for a PWD type 1 young child, the rule of Daphne, dose adjusted for normal eating should be there. Because our first goal is to promote growth and development. We cannot be worried looking at 2,200 calories because that is what his requirement is. And he's having zero insulin production, wherein we need to provide exogenous insulin for the calories so that he meets the growth and development. But obviously we have a lot of guidelines. Based on the guidelines and the formulas, we can arrive at the calculations for his calorie and protein. And since he is on short-acting and long-acting insulin analog, we use the rule of 1,800 and 500 to calculate the ICR and the ISF. And based on this, we will tell him, based on his requirement of about 2,200 calories, I have told how many milk exchange lists, how many nut exchange, cereal, vegetable, pulse exchange or fruit exchange he needs to consume through the day so that he can have improved glycemic control. Now, based on the celiac disease, I need to give my patient options. What are the options which are glycemic friendly, at the same time will not trouble his celiac disease? So these will be few of the options. I need to tell the patient not to use the same tapra which is being used for the other people at home, not to use the same tapra or the cloth which is used to roll the chapati or the velna to prepare the roti. Small tips also are important in order to tell my patient to be free from symptoms of gluten sensitivity. Hypothyroidism, we have another huge list which needs to be incorporated. Obviously small things like keeping away from the milk and milk products at least about 40 minutes, hydrate the patient well. Even something as small as wheat, bulgur and durum and spelt wheat are also moderately glycogenic. Remember that if the patient is consuming a lot of millets, he needs to roast them, sprout them or ferment them prior to consumption in order to remove the goitrogenic property. And bajra needs to be malted for 48 hours in order to prevent the goitrogenic activity. So all the ones which are in yellow are the goitrogenic foods and all the ones which are green are the celiac disease foods which need to be strictly avoided. Apart from that, we have the high GI, high GL, high trans fat, high saturated fat which are usually avoided. Also remember we need to follow the food order in order to have good glycemic control. First the fiber, then the protein and then the cereal portion. So always remember that food exchange list could be incorporated in ideal menu planning, but a lot of permutation and combination and patience is required so that one particular session with the type 1 or a CKD will never work. We need to hand over the family members and the patient for at least a period of 1 month, which would be at least 2 to 3 visits for the patient to get the hang of food exchange list. Thank you for your patient listening. I'll be more than happy to take up questions. I would say as a nutritionist, it would be my responsibility. Oh God, give me food which does not cause any disease and also gives me strength. So whether it's my type 1 or a CKD or an IEM patient, like where MSUD or PKU, I may have to provide exchange list for the patient to have ease in menu planning.
Okay. Thank you, Dr. Meenakshi, for a nice presentation. The house is open for questions. Questions from the audience, please. Any query? Any question you would like to ask? So I think there is no question from the audience. So just a comment that it was a nice presentation and you covered the whole list of exchange food list and mentioned what is the importance of nutrition as far as the diabetes control is concerned. So in day-to-day life, it is very important. The thing is how we can check the compliance of your prescriptions on nutrition. That is the challenge, I suppose, you will be also facing. Although it helps in the overall management of diabetes at large. So any comment like how do you manage, how does check the compliance from the...
Sir, you are not audible, sir.
I am not audible. Okay.
Yes, sir, you are not audible.
Okay.
Your voice is very feeble.
Okay. So thank you for a nice presentation from your side.
Thank you so much.
Excellent presentation, but it requires more time, I think. This type of presentation requires more time to discuss various issues. And what is a compliance means? What proportion of patients are following your advice strictly? So
Sorry, I can't hear anything.
What? Whatever advices you are giving, what proportion of patients are following and what is its impact?
Sir, can you ask the technology person to share the question on the chat because I can't hear
Okay,
it.
madam, okay. Thank you very much for your presentation. I think we are not audible. Thank you very much. Excellent presentation by all standards.
Thank you. You can sign off. We will continue with the other presentation. Record.